Hello class, we're going to review chapter 15, 16, and 17, and it may take a few recordings, but I'll put those in just to talk about the whole surgical patient. Surgery is in 3 phases: preoperative, intraoperative, and postoperative. Intraoperative is, of course, what we consider when they're actually in the operating or surgical suite. Postoperative can include, in your textbook talks a lot about post-anesthesia care unit care, and then how that is transferred over to the nursing unit. In terms of preoperative care, a lot of patients these days will not be admitted the night before surgery. They will come in through ambulatory care and, kind of go through the preoperative preparation in a holding room or area that's right before going into surgery. Other patients, though, you may have, an example would be someone who had sustained a hip fracture and they admitted them to the floor because of the fracture, and then they have a surgery scheduled for in the morning. Then the preoperative care may be provided by the floor nurse. It's very important for that preoperative phase and throughout the whole experience, postoperative, really look at how to care for the patient's physical, mental, and spiritual preparation. I know one of our test questions in fundamentals talked a little bit about, how do you allay someone's fears? Giving them more information is generally a good thing to kind of cut down on the fear of the unknown. But some people are going through surgeries that have very risky conditions associated with them. They may not know whether they're going to live through the surgery. And because of that, many people have emotional, psychological reactions to the preoperative phase, and may need support of clergy and some other types of preparations that they would like to put in place, and we need to support them through that. It's really crucial to identify any of those types of potential needs, and again, with the focus on family that we've talked about, often that is a key thing, is involving family in some of this as well. If you do have a patient that is preoperative, that is on an adult health unit or med-surg floor, there is often going to be a pre-op checklist. That is, in these days, it's not usually a piece of paper. It is something that you're completing in the computer charting. And so the pre-op checklist is going to involve several things, and making sure that you have everything done, and we'll talk a little bit more about what all that will include. Informed consent, now we went over this in previous classes, but obtaining consent is not the role of the nurse, but that of the provider, meaning the physician, who's the surgeon, or the anesthesiologist, who sometimes will get their own consents for the anesthesia portion of their care. The nurse is really responsible to ensure that the patient has all the information that they need, and has the ability to make an informed decision about the procedure. And we've talked about that in terms of having a secondary person to sign for consent. Just realizing that some patient situations can be such that the patient is very confused. The patient could be in severe pain and have received some pretty heavy narcotics. And often it comes down to the nurse really validating whether or not the person is in a state of mind that they really can make an informed decision. If at some reason the nurse doesn't feel that that can be done, then they need to notify the provider right away and not allow the patient to go to the procedure. The patient also has a right to refuse a surgical intervention, and that is even when death is a risk because of that refusal. There are some consent forms that will actually have a place where the person can mark refused and sign. And in some facilities, if a person decides to refuse any kind of care that's been deemed necessary, and particularly if it's a high-risk type thing, there might even be a separate form that you sometimes see that's called a refusal form. These are the components of informed consent. It's going to have the patient's full name, the type of surgery that's being done, all written out and spelled absolutely correct. The reason for the surgery, the name of the surgeon to perform the surgery, and if there are going to be observers or anybody else that would be assisting him, then the name of the assistant physician would typically be listed, or at least a notation that additional people may be assisting. Reason that the intervention will benefit the patient, so you may have a list of benefits there. If there are alternative options that the person could do instead of the surgery, those have to be listed out. Potential outcomes if the surgery is not performed. Some consents will have anesthesia on the same form. A lot of times that can be separate. The same thing will be true with blood products. Some surgical consents will have already listed in there that they are also consenting to have blood products given during the case if need be. But either one of those can have their own forms also. It really just depends on the facility's specific way they have it set up. In terms of a universal protocol, many years ago when we began a quest in healthcare to try to really eliminate errors, as we've already talked about, the universal protocol was put in place by Joint Commission that accredits hospitals. And now you hear people talk a little bit more about it as it's time for a timeout or a pause for a cause. And it often starts when the patient enters into the surgical site or setting. The nurse and other people that are working with the patient will have the patient review their have a wristband put on and verify that all the information in terms of their identification is correct. And then the patient will also identify other information about what type of surgery they're having, just to make sure that they have the exact patient that is there for that specific procedure that day. A timeout is performed once again in the OR suite proper by the circulating nurse when they transferred into the OR, and immediately preceding any incision by the entire team, and before any anesthesia or any kind of drugs are given, they always want to have the patient be involved in marking the site for laterality. Sometimes that might be done on the floor as well before surgery and just re-verified when they get down there. So it just depends. I have seen some surgeons that when they come around to get the consent form prior to surgery, go ahead and mark the site with the patient then, and then just re-verify it in the OR suite. But again, the key thing in patient involvement is making sure they also verified that we were doing something right, because what has happened in years back, there were patients who actually had the wrong limbs removed because someone thought it was the right versus the left, and maybe they had circulation in both legs that was poor, and someone got it completely wrong, and you can't imagine the kinds of problems for the patient that could entail, but also just from a legal perspective. The process for timeout can be can vary between facilities. So how they do it at one place might be a little different than the other. But the key thing is, within an agency, the components of the timeout are consistent always, every single time. And even when you think about, say someone comes to the unit to do a PICC line at the bedside, that is actually considered in many agencies a procedure the patient must consent for, because it is a invasive line being placed. And so timeouts need to even be done on the floor for those type of things, not only in the surgery suite itself. But again, performing a timeout immediately prior to an incision makes an irreversible mistake much less likely. In terms of patient assessment, you're going to see different ways this is done, but by the regulations, we have to have a medical and surgical history available for all patients. Now, sometimes the electronic record may have that. There's really a big need, as we'll see when we talk about respiratory and cardiac in particular, and even diabetes, that chronic illnesses and how well people do when they're under anesthesia or for long surgeries, the care might need to be modified based on chronic diseases that are significant. So we need to know about those up front. In terms of surgical history, you want to know about the presence of implants, because what if you halfway through the case need to take somebody for a procedure, like a radiological exam or something? That can be necessary, and you want to make sure that when you're doing the surgery, you're not running into something physically in the body that you didn't know was there. This PONV, you're going to see that written out in different locations, and it stands for post-op nausea and vomiting. And lots of times you'll see those abbreviations on someone coming back from a surgical case. That's letting you know that this person has a much more severe reaction to anesthesia in terms of nausea and vomiting, and so often they'll plan ahead and have stronger and higher levels of antiemetics and things available in the postoperative phase to kind of counteract that. But they need to know that they've had that history to be able to prepare for that. Of course, the age of the patient is verified, and all allergies. The patient's medication list is reviewed and made sure that that's all accurate and still the same. Their last oral intake is going to be asked, and the key is you like to see all patients be nothing by mouth or NPO times 8 hours prior to the surgery. You also want to have a very open conversation with the patient and try to ensure privacy, to try to see if you can get them to tell you any special considerations, whether there's been a history of any alcohol, smoking, or drug use, because not only do those have implications in terms of how someone receives and tolerates anesthesia, but also even post-operative, if they have the potential to go into DTs because they've not had any alcohol in 2 or 3 days, that could make their post-operative care very tenuous. So having a private area where they can really open up to you and try to engage them in that way is essential. Advanced directives. There are some operative suites still today that kind of the policy is when you're in an OR case, we're going to do pretty much anything we can to revive you. That has kind of changed a little bit with time. Some settings now really try to adhere to whether there's a do not resuscitate or a do not intubate type order for a patient. But we've already covered the Self-Determination Act, and I think you have a good idea that patients can express these things in advance, like end of life what do they really want done, and whether they are organ donors. You want to identify if any of those things are in place for the patient prior to the surgery.